welcome. Today we are celebrating International Day of Women and Girls in Science. And for those of you who may not yet be familiar, it's a day recognized by the United Nations to celebrate the contributions of women in science, but also to reflect on how we can really broaden participation, perspectives, and representation in general in research so that science is shaped by diverse voices and the discoveries it generates are relevant to everyone. My name is Emily Baxi. I'm a neuroscientist and program director for Breakthrough Discoveries for Thriving with Bipolar Disorder, or BD². And at BD², our vision is a world where everyone with bipolar disorder thrives. And that, of course, includes women. So today, in recognition of International Day of Women and Girls in Science, we wanted to focus on women's mental health. For a long time, women have been underrepresented or oversimplified in mental health research, even though there are real biological, clinical, and social factors that shape how bipolar disorder shows up and how care is delivered. So in this conversation, we're joined by three investigators from the BD² Integrated Network. They bring different perspectives and areas of expertise, and together they'll talk about where disparities have existed, what the research landscape has looked like historically, and how the BD² Women's Health Workgroup is working to close and address some of those gaps. They'll also share how this work could shape future research and, just as importantly, how it could influence care for women living with bipolar disorder. It's a conversation about better science, better care, and making sure research reflects the people it's meant to serve. First, a very warm welcome to Drs. Aysegul Ozerdem, Pamela Mahon, and Benicio Frey. Dr. Ozerdem is a professor of psychiatry at Mayo Clinic. Dr. Mahon is an assistant professor of psychiatry at Harvard Medical School. And Dr. Frey is a professor of psychiatry and behavioral neurosciences at McMaster University. And all three serve on the BD² Women's Health Workgroup. So thank you for taking the time to join me today. And before we dig into questions, I have to say it is a joy to work with all of you, in no small part because of the real passion and dedication you bring to solving some of the issues we'll discuss today. So thank you for that. Let's start by gathering a little context. Aysegul, what has the landscape of research on women with bipolar disorder looked like historically?
It is not only women with bipolar disorder, but historically research on women perhaps with mental illness. But more specifically with bipolar disorder, it's been shaped mainly by how women were included or excluded from clinical research overall, and women-specific clinical questions that drove dedicated study, especially pregnancy, postpartum, and medication safety. So early clinical description era identified childbirth-linked severe mood episodes, and they were well recognized long before modern diagnostic criteria or systems. Postpartum psychiatric syndromes and their links to what we now know is conceptualized as bipolar spectrum illness. Now we know that many postpartum psychosis episodes are best understood as manifestations of bipolar vulnerability triggered by childbirth. Mid-late 20th century, women often not systematically studied in drug development, and especially those of childbearing potential were often excluded from early phase drug trials. And in 1993, until 1993, when policy turning point for inclusion in clinical research came about. And two major developments in 1993 changed the landscape. One is the NIH Revitalization Act, and the second one is FDA guidance on sex differences. Both came in 1993. But despite that, did the unmet need was it met? Not really. we may come back to this topic and discuss, how well we actually study the sex difference in treatment of women with bipolar illness. And in 2000s, gender differences in bipolar disorder became a more defined subfield. Sex gender differences in bipolar disorder, like course patterns, polarity, rapid cycling, comorbidity, depression being more predominant in women, were more clearly identified. And also perinatal bipolar research expanded with more quantified relapse risk and medication safety synthesis. Medication safety in pregnancy postpartum became essential evidence base. And in the last decade, stronger mandates came to analyze sex regulatory tightening for teratogenic medications, etc. So I will leave it there to my colleagues to continue.
No, it's really helpful, and I'm struck by how recent many of the changes and the acknowledgments are for the field. So, Benicio, Pamela, I don't know if you have anything you'd like to add to that.
Sure. So I think, Aysegul gave a very nice overview of the history of research in women's health, women's mental health. And I think another aspect to this is when people think about research in women's health, they think naturally about obstetrics and gynecology. And that's really where a lot of the research has been and where a lot of the focus has been. And so research on women's mental health has been underfunded and underprioritized, given that that's where the focus has lied. I think that there's been this tendency to focus on conditions that impact on women exclusively, like in obstetrics and gynecology. But there are so many examples of where women's mental health either differs from what we would see in men in terms of course or outcomes, or that there is a predominance of disorder in women as compared to men. And we see this in things like depression and PTSD. So I think those are some other areas where we've really seen the lack of prioritization of women's mental health historically.
So just to add to what my colleagues just said, first of all, I just want to briefly add a preamble that some of the women's mental health issues that we are discussing here today are also applicable or relevant to many individuals that don't self-identify as women. So I think it's important for us to acknowledge that as well. So beyond the perinatal mental health area, we know that bipolar disorder is also highly comorbid with other reproductive life events, issues such as, premenstrual worsening, and more recently it's been acknowledged that perimenopause as an area of that's very tough for a lot of individuals, they're receiving treatment for bipolar disorder. They tend to get worse in the menopause transition, and then why does that happen? As well as even new onset bipolar disorder. Also, there's some evidence from the literature that menopause transition is one of the periods of vulnerability. So I like the term hormonal sensitivity because it's really not about, there's nothing wrong about their hormones. They can get pregnant, they can have like regular menstrual cycles, normal sexual life. It's about the fact that some individuals are more sensitive to those reproductive life events, and that is presented with vulnerability for symptom worsening in terms of their mental health. So beyond the perinatal, I would say also that, how much the menstrual cycle affects bipolar disorder, how much the perimenopause affects bipolar disorder, hugely understudied and exciting areas for future research. Having said that about the history of women's mental health being, less valued and less researched, I must say that it's very exciting for me to see, a trend of a change for that. I haven't seen as much discussions, as much forums, as much even, some targeted grant opportunities here and there for women's mental health specific research. So, with all the negativity that we see sometimes in social media, I'd like to point out that it's an exciting time now that this issue is now becoming more and more at the forefront of research and funding agencies. That I hope we are seeing a bit of a positive change in that regard.
Great. Thank you, Benicio. And you introduced a topic there that maybe I can ask you, Pam, to dig into a little bit more. But this idea that reproductive transitions can affect the bipolar course. So why is that so important to study, and how do you think we can make headway in that space?
For the clinicians, for instance, oftentimes they don't know how to even assess, for instance, the influence of menstrual cycle on individuals with bipolar disorder, because this topic is generally not even taught in residency or even medicine in general. One of the things that I've been pushing, strongly, is for a better place of women's mental health in the educational curriculum of residency programs and medical schools, so then we can, better train the future clinicians that work in this area. How often we find clinicians asking for help of things that, a simple training and understanding how to assess those individuals will make a huge difference. And patients telling us how much their complaints about their menstrual cycle or their perimenopause have not been properly addressed. So I think the assessment is certainly something that can be like really important to to teach and to be more formally trained.
Maybe, Pam, can you speak to how much data is out there to help clinicians and researchers understand those transitions? Is it available?
So I would say there is a growing literature that is there to help support clinicians understand the impacts across different reproductive transitions. If we think about research, there's been a big push to study sex as a biological variable, which is fantastic, but it means that a lot of the research has really focused on sex differences, comparing women as a whole to men as a whole. And so if we think about reproductive transitions, it's really important to understand the unique factors that are happening across those transitions, not only the changes in hormones, but also other changes in terms of social factors, et cetera. So there is a growing body of literature out there that is available to help understand this. There's been a lot of work in understanding transitions around depression in pregnancy, around the menopause transition, menarche and the onset of puberty. There are places and work that people can refer to better understand this that's starting to come out.
And how do you think the work that we're doing with BD² and the integrated network can add to that, making sure that it is robust enough and really comes to awareness in a way that impacts care in a meaningful way?
I think we have here a tremendous amount of opportunity with BD² because we have participants, both men and women, and we have participants at all ages, adult ages, and we have a longitudinal follow-up opportunity. So when we look at our sample, it is a wonderful opportunity that we'll be able to see at least 5 years of an individual in their lifetime with bipolar disorder. And when you think about a woman who might be age 35 when she's enrolled in BD², and then by the time we continue the follow-up, she may be transitioning to perimenopause, etc. Hormonal significant hormonal transition period. And there is no other study looking at this prospectively that we will be able to look at together with both clinical, psychiatric, and also biological aspects of it, because we will have biosamples from those individuals and we'll have the opportunity to look at their clinical course of illness together with their medical comorbidities and psychosocial stressors at the same time. So it is an unbelievably great opportunity, and we need to make the best out of it. For instance, in literature, definition of perimenopause is usually based on age, between ages 40 to 55. And then no definite clinical diagnosis exists in many of the studies. And we will have that opportunity because we are questioning, asking the right questions to define that period. For instance, this is one thing. And we are also seeing women with reproductive ages, what happens with their menstrual cycles, and biomarker study, for instance, EEG, brain imaging, blood-based biomarkers, the sex difference or, sex-based analysis are not there in literature. It is growing, but it is still scarce. So we will have the opportunity to look at all of this, and the reflection of all this data and the subsequent analysis, the outcome will significantly contribute to the well-being of our patients. For instance, for predictive factors of how they will do for women, particularly, for instance, in reproductive ages, and how they will do maybe in while transitioning to menopause. Predictive factors are very important for an individual's well-being. We will have preventative measures based on those predictive factors. I mean, this is only one thing that I can think of. I'm sure Pamela and Benicio have a lot more to say.
No, that's incredibly helpful. Thank you. It's really about building a data set that is comprehensive
Yes.
and longitudinal, so the
Yes.
information can be put in context so that it can be applied in a better way. Yeah, Benicio, please.
Absolutely.
Yeah, so beyond the sample size and the longitudinal design that is required to answer many of these important clinical questions is the fact that this is a study done like with real world patients, right? Which also gives an opportunity to plug in like specific projects, specific, research questions that can be, iteratively answered by the learning health systems model, and see, for instance, one can plug in randomize a trial, let's say, to act on a risk factor that has been identified, and how does that clearly prevent future symptom worsening in that population. So the ability to also support additional targeted research questions linked with the learning health network is a great opportunity.
Maybe sticking with you, Benicio, how do you think, from your clinical practice, having data like this helped address some of the challenges that you see in women or other people who have been typically underrepresented in research studies in the past?
Yeah, so I think a lot of the skepticism or undervalue of this research comes in part with not enough original research showing, how robust the link is in many of the areas. So I have no doubt that because the results coming from this large data set will be so robust that will be ultimately what we need to really spread the word and show clinicians out there, and researchers and funding agencies, how strong the link is, how important the women's health issues are for those with bipolar disorder. And there's nothing better than original data and robust data to move the needle up. And I think that's where the BD² network will make like a tremendous impact on women's health issues with this data set.
Great. Thank you. Pamela, are there any areas where you see the data was just entirely missing before this, and you feel like the integrated network will be able to provide very novel insights?
Absolutely. I think the research to date is really missing the unique experiences that women living with bipolar disorder have across their lifespans. There's pockets of research focused on very narrow periods, but this really will allow us to have a full picture from young adult through older age as to how women experience bipolar disorder when they are developing and aging. I think that's one major area that this project will be able to have a huge impact.
That's terrific. Thank you. Aysegul, drawing on your experience focusing on women's mental health, as you entered into this area, what was most surprising to you to find that was either under researched or just an observation that had not been followed up on?
Um, there was a lot. But I have indicated when I first started answering your very first question. Clinical presentations involving peripartum, postpartum are well known, and there was a very much interest and focus in that area. But the rest of being a woman was sort of left out in bipolar disorder, not only in bipolar disorder, but with depression, with other mental illnesses, and even in other fields of medicine. And we've started focusing on the other aspects of being a woman with bipolar disorder. For instance, medical comorbidities, how they appear in women with bipolar disorder across lifespan. What's their response to stress? Based on different reproductive stages, for instance, it is still understudied, under researched, and not focusing only pregnancy and postpartum related issues, but other hormonal sensitivity part of the study of the story is important, and it was really a neglected area that was surprising to me. And I think we together with Benicio, we have published a special issue in journal Bipolar Disorders, focusing on different aspects of women with bipolar disorder. That was a unique publication, I think, and that was the body that published make that happen. That publication made happen was the Women's Health Task Force of the International Society of Bipolar Disorder. And it was a great effort, one of the first pioneering task force, I would say, in bipolar disorder for women with bipolar disorder. And ever since, I think the research picked up, and there was a lot of interest, but not a lot of research done and published. But since then, it's been more than a decade, maybe 15 years. There has been a lot going on, and we are in a much, much better place in terms of defining, describing, and researching the other areas of being a woman with bipolar disorder.
It sounds like there's momentum gathering. It may be,
Yes.
it may have taken longer than any of us would have wanted, but at least there's now work at play. And I think incumbent on
Absolutely.
us to continue to support and do that good work. A question for all of you. The part of the integrated network that I find very helpful is that it is bringing clinicians, researchers, and people with lived experience together to think about what are the research priorities, what are the most desired outcomes. And I wonder if each of you could comment just on what you think the unique strengths of that are and how you think that will enable research where it was perhaps a little more challenging in the past. So I'll start with you, Pam.
One of the wonderful things about this model is the questions that we ask in our research can be really informed by individuals who are living with bipolar disorder, and that can then directly inform changes in clinical care and approaches. So it's really important that we have all the different stakeholders together at the table when we're thinking about what do we want to address first when we're thinking about women with bipolar disorder. There are so many questions, as we've already discussed, that are left unanswered. And so prioritizing research questions, clinical questions that are a top priority for the patients for individuals who are living with bipolar disorder is really going to be a fantastic way that we can have a real impact on people's lives.
Great. Thank you. Benicio?
Yeah, I certainly agree with that. And also, working with people with lived experience, we make sure we don't miss the most important areas that need to be studied from their perspective. Sometimes we researchers can come up with what we think is a great idea, but not necessarily are the priorities of people living with the condition. So, having this co-design and interactive approach also ensures that the most important areas from their perspective are not missing. And also on top of that, knowledge dissemination, I think, is a great stage to engage with people with lived experience when they help us disseminating some of the material, translating the material into, patient and family terms, presenting together. More and more, we see researchers and people with experience together in, workshops and conferences and co-developing written and um, online products that can only improve the dissemination of these results.
Great. Thanks. Aysegul, anything you would like to add to that?
Another great point of this model is that it brings basic scientists, clinicians, and the patients, to lived experience. So it is a great spectrum working together and interacting and informing each other. And I think that is a great model to inform needs of, the patients and their families, coming from very basics of it up to the daily life. So it is a great integrative model.
So maybe taking a step back and asking you to think about, yes, we're going to do this work over the next number of years, but in 5 years plus from now, for each of you, what would you want to see as the greatest changes to care and practice that you think will really help and really create better outcomes? Nitya, I'll start with you.
Yeah, I think one of the I would say main things I would love to see is the support for the next generation of both researchers and also clinicians. I would love to see support both from funding agencies, but also educational curriculum associations to support young people to join this change, so this change can be sustainable over time.
I think one of the wonderful things is we'll be able to build on the evidence base for clinical care. And once you do that, you can disseminate that evidence base more broadly and really contribute to education. So I think one of the challenges we see are there are huge areas geographically where there aren't psychiatrists who feel comfortable prescribing medications for women during pregnancy, for example. And so if we can increase that evidence base, enhance dissemination of that to clinicians, I think we'll see greater capacity for our medical systems to care for women with bipolar disorder.
Thanks. Aysegul.
I fully agree with Benicio and Pamela. And in addition to that, I believe BD² will give us the opportunity to see how differently women might be responding to treatment, both pharmacotherapy and psychosocial interventions, and that can also encourage clinicians, in different settings, to be more encouraged to treat bipolar illness with more confidence, and kind of with more knowledge that women will look different, but they don't have to fear that, and because they will be supported by more evidence.
That would be a strong place to be. But just a question that comes from that, are there any learnings from studying women that would be more broadly applicable? Like, how does this change care at a more general level? Are there things that we will learn that will influence care overall so that it is better?
Yeah, I mean, we've been talking about hormonal transitions, and
Hmm.
just knowing the fact that women will change in treatment response over the course of years, not only because of biological aging, but the hormonal changes that come with it and how the aging and hormonal changes interact. So I think awareness on it in and itself is a significant step forward in patient care, care of women with bipolar disorder. So I think that is something that will bring this, important initiative will bring to the literature and also daily practice.
Thank you. Are there things that you feel are top of mind for women that they don't feel are understood or recognized when they go to their clinician today? What springs to mind as something that you hear on a regular basis as really not being acknowledged in the way that we wish it were?
Yes, I think an easy answer is the influence of reproductive life events on their mental health, right? Quite often we hear that because the patients they know they were doing well, they know they've been treated, they know they've been using their medications and implementing their psychotherapy, so they know that all of these things that are happening right now in their lives, for instance, is because their menstrual cycles have become irregular upon the early perimenopause, and they're still struggling out there with clinicians not paying the right attention to that possibility and trying to manage their mental health in more, let's say, quote unquote, general terms. Let's say using general guidelines for depression, general guidelines for bipolar disorder, and not really diving into the possibility that it's the hormonal influence behind it and other things that one can do. For instance, discuss hormonal replacement therapy or contraceptives if they are younger, or other things that can be important. And the other thing that is very important is how relieved they are when we assess them and we give them this understanding of the influence of their reproductive life events on their mental health, in terms of how they perceive that the care has been more precise. Like it's they're looking at me, this clinician is listening to me, because I haven't been heard, out there. Like it's unfortunate, this is still very much a reality for a lot of people suffering from these conditions, like the hormonal sensitivity.
Yeah. And recognition that that is
Yeah.
playing a part
Yes.
in their lives. Yeah.
Yeah.
Makes a lot of sense. Well, we've talked a lot about how science and research can and I would say must work to improve mental health care for women. And an important part of that is making sure women and others who have been historically underrepresented in science and research have a seat at the table. So, as a closing thought, could each of you share a piece of advice for building a successful career in science, especially for those who are coming from underrepresented backgrounds? So, perhaps we'll start with Pamela.
I think it is so important that people in our positions serve as mentors and really help guide individuals who are interested in pursuing careers in research. There are many different opportunities to do that through travel awards and societies and providing direct mentorship, but also sponsorship. And so I would really advocate for anybody who's in a position to help somebody start their career in research, to help them maintain their career in research, that is a fantastic place to start. And then for those who are starting out in research themselves, reach out to us. I think that there's sometimes an invisible barrier where people feel like they can't reach out and ask to talk to somebody whose work they're interested in. And I would say that if you're interested in something that somebody's doing, reach out, ask them to talk. It's exciting. We like to talk about research, and I think that it's an opportunity to learn more about what everybody's doing and to really form a community of individuals who are working in these areas of research.
That's really great advice because I think we are excited to help and support and transfer knowledge and, as you say, grow a community. Aysegul, would you like to share some advice for growing a strong career in science and medicine?
I agree with Pamela 100% and not be shy. Seek help. Ask questions, more questions, and be vigilant of societies that have particular task forces for early and mid-career scientists and clinicians. Join those and be present. Present yourself, with your writings and, presentations. So the more questions you ask, the better support you get. That is for sure. And also for us to continue our awareness and improve it to include early and mid-career women in science and in efforts or big institutions or initiatives like BD² or other societies. Invite them more, identify those and invite them more, involve them more in doing, creating. They're going to be excellent observers and they're our future. Without them, anything and everything we do will go into waste. So we need to be more open to them as well as we expect more from them. But we are here to be with them, to grow with them. So I always learn from my young colleagues. It's a great opportunity for both ends, I think.
I love that. That's a great thought. Benicio.
Yeah, I just want to congratulate BD² for even doing this with us here today and talking about women's and girls in science. I'm happy, of course, to see more and more academic institutions having policies on equity, diversity, and inclusivity. So it's very important for us to support that work and support those local committees. So the inequalities that we've known being historical can be lessened as a problem for our future generations.
Very well said. And I think the more diversity we bring into the pipeline, the more we can learn and enhance science for everybody. So a really important part of the mission. I want to thank all of you for sharing insights and for the work that you do every day to advance more inclusive and impactful science. I want to thank everyone for listening and joining to mark International Day of Women and Girls in Science. And we hope you continue to follow the work of BD² and the Integrated Network, and in particular, the BD² Women's Health Workgroup. Thank you all.